Surgical approach for tractional or combined tractional rhegmatogenous detachments. I'm Mohammed Al-Masri. I've presented this presentation in the EGVRS focus meeting in October 2024. So the problem is when we face a case like this with a tractional retinal detachment, what to do. So we have to know the steps of surgery for tractional retinal detachments. The steps that after core vitrectomy, we identify the plane between the posterior hyaloid membrane and the traction combined and the retina, and we remove the posterior hyaloid and traction from this plane from the retina. We control bleeding points, we manage holes and breaks, we do anterior vitreous shaving, and we do endo, laser, and tamponade if needed. This presentation is going to approach how to identify the plane between the posterior hyaloid and the traction combined and the retina, and how to remove the traction in combination with the posterior hyaloid membrane. So first, to start with, the approach for the surgical plane. The state of the posterior hyaloid membrane in the diabetics during vitrectomy, it's tricky. It's either completely detached, which is rare, or it is partially attached, which is somehow common, or it is totally attached, like this case, and it's also common. And we have to beware of the vitroschisis, which is the splitting of the posterior hyaloid membrane. There is an extra layer of vitreous attached to the retina, always, which needs to be stained, as we're going to show. So how do we find the plane? We find the plane in a partially attached hyaloid and traction through an area of a subhyaloid hemorrhage, like in this video, where the subhyaloid hemorrhage here is between the posterior hyaloid membrane and the retina, so it's easy to attack this plane through the hemorrhage. Or if we have a thick fibrotic posterior hyaloid membrane with bridging traction, like in this case, where the posterior hyaloid membrane is bridging areas of traction and it is cut by using a sharp instrument like a 23 gauge needle, then the hyaloid can be elevated, like in this video. So, but if we have a totally attached posterior hyaloid and traction, so we have to find the plane through either a central to a peripheral approach, like in this video where we're going to elevate the fibrous NVD from the disc. Here the membrane is totally attached with the traction, so when we remove this membrane from the disc, the PVD starts, or we can go from the peripheral to the center if we do vacuum on the peripheral hyaloid, or we can remove gently a peripheral membrane and go from outside inside. This is a case where the peripheral hyaloid is removed first, and as you can see, the wave of the posterior hyaloid, it's now being detached. And now when we detach the peripheral posterior hyaloid, we can find the plane to go and tackle the traction. If we don't find the plane and try to tackle the traction from above below, here we can do iatrogenic breaks and we will not remove the whole membrane, which may compromise the result of the surgery. So now we are in the right plane. How to remove the membrane? The separation of the membrane and the hyaloid from the retina, we have facts for dissection. As I previously mentioned, the fibrous tissue is continuous with the posterior hyaloid membrane, and these membranes are adherent to the retina. And there are some things that are called epicenters, which are the points of attachments, which are the stalks of the NVEs. So aggressive peeling may peel the retina due to the firm attachment between the traction and the retina and may cause retinal breaks, and this will compromise the result of the surgery. So we shouldn't aggressively peel the membrane from the retina, because if we peel here, this is the point of traction, and the retina is ischemic and atrophic, it may break. So if we have broad membranes or bridging membranes, they should be divided into smaller pieces, and this is called segmentation. And segmentation allows the alleviation of gross tractional forces, like in this case. We have a big membrane which is attached on the retina, so before removing the membrane, here I am segmenting the membrane with the vitreous cutter into small pieces to relieve the traction of the retina, and then these smaller pieces may be eaten again, as I'm going to show you. So, how do we segment with the vitreous cutter? But after segmentation, we have to cut the attachments between the fibrous membranes and the retina with or without minimal pulling, rather than uncontrolled peeling. And this is called delamination. Like here, we are using the vitreous scissors to cut these epicenters so that we can dissect the membrane from the retina. Here the scissor is used to gently elevate the membrane, finding the point of attachment between the membrane and the retina, and then it's cut. Now the membrane is free in this part, but we have another epicenter. We keep cutting until we remove the membrane with the scissors. Delamination also can be performed using the vitreous cutter by using a high cutting rate between 5,000 or 7,000, even 10,000 or 20,000 cut per minute, with low vacuum according to the cutting rate. My parameters, I use 7,500 cutting rate and vacuum between 250 up to 400 according to the retinal mobility and the thickness of the membrane. Here we use the vitreous cutter with either a conformer delamination, which means that the vitreous cutter is moving in the space between the traction and the retina. And the vitreous cutter, when it moves, we feed the port of the membrane to the vitreous cutter, and it moves on the retina and shaving the membrane, like in this video. Here we feed the membrane to the port of the vitreous cutter, and the vitreous cutter can eat the membrane, segment it, and then delaminate it. Here we are segmenting the membrane, and then delamination, they can be combined with each other. And this is the conformal delamination. We eat the or we have another technique for delamination, which is called the fold back delamination. And here the vitreous cutter is above the membrane, and the membrane is slightly freed by gentle vacuum from the retina, and the vitreous cutter, the membrane is folded back into the port of the vitreous cutter. So here the vitreous cutter is above the membrane, not between the membrane and the retina. Like in this case, gentle suction, the hyaloid is elevated, the membrane is a bit elevated. Now, without pulling a lot, so as not to injure the retina, we can use this type of delamination that the vitreous cutter moves and hovers above the membrane to eat the membrane away from the retina with gentle vacuum. So these are the types of delamination. When we talk about combined traction rhegmatogenous detachments, the traction here caused a break, which invited subretinal fluid, and the detachment has a convex configuration. We have the same approaches for these cases, such as we have explained before, but beware that the retina is mobile, so we have to use lower vacuum with the vitreous cutter. And actually, in these cases, the bimanual technique in my hands is used more. Here, the posterior hyaloid is attached in the periphery. I'm using here the tanoscraper to elevate the peripheral posterior hyaloid to find the plane of dissection between the posterior hyaloid and the retina. And this plane is continuous with the plane of dissection between the traction and the retina. And then the bimanual technique is used using a forceps and a scissors here to cut the epicenters and remove the tractional membrane bit by bit from the retina. Here the retina is mobile, so the use of the vitreous cutter is a bit limited, and the use of the scissors in combination with the forceps is used more. We have to beware of vitreoschisis. And vitreoschisis is the splitted posterior hyaloid, like in this case where the posterior hyaloid here is very adherent, in this case of a simple hemorrhage, and this hyaloid is adherent on the retina, where if it's left, it can cause contraction after doing PRP and may open laser scars and may cause a detachment. So it's very important to stain with triamcinolone. I prefer staining the triamcinolone late and during the surgery, if I feel that I finished everything, so that if there is a separate layer of vitreous adherent to the retina, it should be addressed during the surgery. Thank you so much, and if you have any questions, you can leave them in the comments. Thank you so much.